All right. Well, again, good evening, everyone. Welcome to the third in our series of emergency medicine at sea, presented by Alex Cullen, who's the director, as you can see, the director of GW Maritime Medical Access. Really great program at GW University and Hospital. Highly recommend it. I'm a user, and tonight the topic is musculoskeletal. I'm just going to mention now our next topic is going to be GI and seasickness. And then the last session, session 5, is going to be on sailing concerns and medical concerns for those of us that are sort of in the, I'll be nice and say over 50, 60, and maybe over 70 range that are out here. But I'm going to say this now, and I'll try to remember to say it at the end. If there's any other topics that you'd like covered, let us know. And Alex has agreed to probably fit them into the end of our last session. So with that, I'm going to turn it over to Alex Cullen.
Thanks, Alex. Good evening, everybody. As Alex said, I'm the director of Maritime Medical Access, but I'm also a avid sailor and paramedic and flight paramedic by trade. So I've done a few, pickups off the back of a sailboat and a few evacs where we've had musculoskeletal injuries. I do want to tell people that there are some pictures of broken bones in here. Nothing super gory, but I don't want anyone to be caught off guard. As Alex alluded to, this is number 3 out of 5 that we've got scheduled. So if you missed the prior 2 talks, I think they're available online through your portal. And the next 2 will be on the 15th of April and the 6th of May, respectively. If there's anything you'd like us to add to the repertoire, I'd love any feedback you have. At the end, there's going to be a QR code if you wanted to drop any comments my way so that we can improve this for the next year or for future talks. So thank you guys for your time this afternoon and evening, and let's get into it. So it turns out that sailing as a sport has some pretty interesting injury data associated with it. And last week, last talk, I mentioned that 10% of the calls we get to Maritime Medical Access involve skin infections. Well, it turns out that a large majority of the other injuries on board sailboats, not necessarily people that are calling me, but in general, are actually musculoskeletal in nature. And that really is no surprise because you'll see sort of what we can highlight here. The vast majority of these things are going to be sprains and strains. You can see that in the first column, sort of 68% are sprains and strains. And that tends to be because of the environment that we are in. I think what we're going to talk about today is the multitude of musculoskeletal problems that can happen on board a boat, what we can do to assess them accurately and figure out if this is severe or if this is sort of something that'll go away by itself, when we need an x-ray and when we don't, and how to communicate that to any sort of on-scene medical providers. And then also some tools and considerations for things to have on board to mitigate problems if they do occur. So how does this happen? Fall down, go boom. It's the usual injury pattern for a musculoskeletal trauma. On land or on the sea, it turns out gravity is always on. And it has an unfortunate ability to catch us off guard. And frequently when we're holding things or when we don't have the ease of catching ourselves. So we're going to talk about how impacts with the ground or impacts with other objects can injure the human body. When you look at what causes musculoskeletal injuries at sea in particular, I think that there's sort of 6 or 7 things to highlight. One of them is that we are on an unstable platform. If you're walking on the ground, on the street, it is uncommon that the street moves and you don't see it coming, right? Aside from like an earthquake, or an explosion. The ground is pretty stable, but on a boat, not so much. And again, if you're a monohull person, you're used to a little bit more motion maybe than a catamaran. But again, nonetheless, all of these things are unstable platforms. I think the next piece of this is uneven surfaces. I think everyone's first couple weekends on a new boat walking around, they find out all the things you can break a toe on, sort of by experience. And so just think about all of the like blocks and lines and handrails and eyelets and the gunnels and all of the things on the boat that are there for a purpose, but that when you step down on them wrong, a hatch is another perfect example, a line on the deck. All of those things are going to give us uneven footing and uneven stances, and that can increase our risk specifically of ankle injuries. Or if we trip on those surfaces and catch ourselves with our hands, we can see wrist, arm, shoulder injuries as well. Unexpected moves, again, the easiest way to hurt yourself is do something quickly. And the reason that I say that is because when we react to things, we don't always have self-preservation on. And I'll give you the example. If something goes to fall off of a table and you reach to grab it, you might reach to grab it and hit your head on that same table. And it's because you focused on that quick, urgent move and not on the self-preservation. And so people have problems with this anytime they're doing something quickly. Tripping hazards, as we alluded to before, the sheets, but also the lazy lines and anything that's on the deck itself, dock lines on a dock in the evening, hoses, electrical lines. There's all sorts of stuff just draped around the place, whether on board or on the dock, and all of these things can be a tripping hazard. To also conclude, Caribbean roads aren't the best for rollerblading because they're not usually very flat or well paved. So again, just all the things out there that can cause us to trip could give us a problem with both our lower body and our upper body if we were to fall. We talked a little bit about lines and ropes. Again, for me, there's the simple trip on it. There's the more complicated, somebody went to let out the sheet and I was wrapped up in it. And then there's the, God forbid, sort of terrible, the line broke and I got hit by one of the bitter ends or working ends of that line. Overuse, this is a big problem with shorthanded folks, is that if you're grinding all day because you're sailing upwind and you don't have electric winches, you can overuse your arm, shoulder, back trying to get that sheet in, and ultimately we can end up with some overuse injuries. I think the other thing that you see is a lot of people have like their winch arm. And so we end up with a lot of tension over on one side of the body, and the other side of the body doesn't have that tension. That also is going to make us more prone to back injuries, especially lower back injuries. And then risk factors, again, anybody who has any sort of arthritis, osteoarthritis, osteoporosis, any of those things that can be considered a risk factor for injury. I think the other part would be a history of instability in a joint. All these things are going to be worth considering when we go out. So today we're going to talk about sprains and strains, what the differences are, dislocations and fractures, and a little bit about sort of the chronic factors associated. And we're going to sort of go through this in a somewhat organized fashion. So let's talk about the bones first. The human body at adult form is made up of 206 bones. And this is just a cool little infographic that has a name of every one of the bones for where it is. I don't think it's worth knowing the names of all of the bones, but I do think it's worth understanding that there's a lot in your hands and feet, and that the rest of the body is sort of laid out in a relatively well-planned, symmetrical manner. There's some symmetry to the bones. So if you think about humans as if we were a dog, so to speak, our upper arm and our upper leg both have one bones, and our lower arm and our lower leg both have two bones. And then our hands and our feet have effectively the same amount of structures in them between the two. So if you look at our appendages, if you will, we've got a pretty mirrored structure throughout all four of our appendages. Our skeleton does a lot for us. It lets us move. It gives us our structure. It protects our vital organs, right? We've got a cage for ribs here, and those ribs are going to protect all of our vital organs. Anybody who's ever broken a rib knows that you use your rib cage all the time. You just don't think about it. Some other things, though, that most people don't think about, your bones actually make your blood. So every one of your bones is full of marrow, and that marrow is constantly manufacturing blood cells. Those blood cells are going to be your red blood cells, which carry oxygen, but also your white blood cells that fight off infections. Again, I think topographically, there are people that have bone diseases. And if you have a bone disease, you're going to be more likely to have bone problems, whether that be, too much bone or too little bone. And then there's also people that have injured themselves in the past. And so if you break a bone, it's not necessarily you're more likely to break that same bone again in the same place, but that you've already done it once, proven sort of that it's doable. When we zoom in a little bit, so this is a right ankle, you've also got joints, and joints are where bones come together, and they come in a couple different formats. A hinge joint is like your elbow, and your elbow is capable of doing one thing. It can't really move in any other orientation. It's very strong, very sturdy, but it is not very mobile. Then you've got a ball and socket joint, kind of like your shoulder. And your shoulder is really mobile, but unfortunately not as strong. And so we'll talk about how that is impacted. But again, just to come back to my prior statement about mirrored sort of symmetry, your hip is a ball and socket joint and your knee is a hinge. You've also got sliding joints, and your wrist is a good example of this. It's actually a union of multiple bones. It can do hinge motions really well, but it can also do a couple other things because the bones slide over each other. Just keep in mind that you can only fracture a bone. So anytime someone says they broke their shoulder, you can't do that. You can injure it, but you can't break it because it's not a bone. You could break all of the parts of it. Ligaments are the straps that hold your bones together. And so you have ligaments all over the place that are attaching bone to bone, and they're not very flexible and they're not very vascular, so they're slow to heal. And we'll talk about that later on when we talk about sprains and strains. We'll also be talking about tendons. Tendons connect muscles to bones. And so, the most famous of tendons is probably the Achilles tendon, and it attaches your calf muscle to your calcaneus or your heel bone. It's the sort of tough thing on the back of your ankle. So when we talk about this, if I injure my foot and I see bruising on it and it hurts, I could have a sprain, I could have a strain, I could have a fracture. And that's going to be based on what part of the anatomy I've injured. And again, we'll talk about that a little bit more here in a minute. So a sprain is a ligament problem. A strain is a tendon problem. Both of them can be problems in the same part of the body. You can strain and sprain your ankle at the same time. You could also break a bone. So what I want to think about in your use case is if somebody steps off of the settee a little bit, we take a roll, and now I've got a painful ankle, it's swollen, and it's black and blue. And I want to know whether or not I need to take that person ashore and get an x-ray, or if they can just keep their feet up and try and be careful and keep cruising. And so again, later on, we'll talk about some rules for how to figure this out. But do understand that strains by themselves usually heal relatively quickly. The muscle and the tendon is very vascular, and these things heal well by themselves most of the time with rest. Ligament injury is going to be really problematic if it's a grade 3. That is, the whole thing is torn. Grade 1 and grade 2 ligamentous injuries are okay because they can heal on their own in the right position, whereas grade 3 ligament injuries typically are going to involve surgical fixation. Um, Ligaments are this interesting material, and they're hard for us to mimic in material science. So what you see with a lot of ligamentous injuries is people having like cadaver ligaments actually installed because we can't manufacture something that's as strong but as flexible as it. And attaching them to the bones can be difficult. So a lot of people think of a fracture as the worst thing in the world, but fractures tend to heal in like 6 weeks. Strains tend to heal in less than that. A ligamentous injury could go on for months, if not forever, without a surgical fix. And so I do want everybody to understand that fractures aren't great, but a bad ligament injury can actually be worse in healing timeline than a fracture can, again, given the circumstances. Again, we'll talk about how to prevent these, how to fix them, and how to try and figure out which one we're looking at here in a minute. Okay, so muscles are a part of our daily lives. The human body has a lot of different muscles in it and a couple different types. The one we're going to talk about today is called skeletal muscle. And this is the muscle that you use to move, or the muscles for locomotion. And the idea with your muscle is that you have a muscle cell, and that muscle cell can go from being this long to this long. And when you put a bunch of them together, you get a rope. And that rope can go from being this long to this long. And when you get a bunch of those ropes together like strands, you end up with a muscle fiber. And that whole thing is encased in a sheath, just like one of your sailing lines is. And so each one of those fibers can individually move, and each one of those sort of bundles is wrapped together in this really, really sort of tough stuff called fascia. And then those fascicles form like the total muscle. And so when we think about how our body moves, each cell gets shorter, and as each cell gets shorter, each fascicle gets shorter, and as each fascicle gets shorter, each total group gets shorter. And that's what allows me to move my elbow. Now, because muscles only pull, in order to bring my arm back out, I need to use a muscle that opposes this one. And so I have a muscle on both sides of my arm that allows me to move my arm in two directions. Again, muscles are unique in the human body because the way that we make them stronger is by breaking them down. And so this will be important later on when we talk about some of the other problems you can have. But if you work out, you break down some muscle, and when it builds itself back up, it's a little bit stronger. And that's good if we want to build muscle. If you break down too many muscles at one time, you can end up with a problem because as you break down the muscles, there's a little bit of muscle dust that can get stuck in your bloodstream and eventually clog your kidneys. So we'll talk about that a little bit down the road here as well. So some terminology that I think is important if you're ever describing what's happened. A closed fracture is a fracture where there is no break in the skin. So someone fell down, broke their leg. We can't see any cuts or bleeding externally. That is a closed fracture. An open fracture is any time there's a fracture and a cut. You don't have to see the bones sticking out like it's depicted in this picture here. I think the biggest concern here is that in an open fracture, we have a significantly higher chance of infection. And that's going to mean that we're going to be more aggressive with antibiotics because we want to make sure that that infection can't get into the bone because the bone makes your blood. So again, bone infections quickly can become blood infections, and then we have a systemic problem. Transverse, spiral, and oblique fractures are all describing the pathway through which the bone is broken. So in an oblique fracture, it's a diagonal. In a transverse fracture, it's across the middle. And in a spiral fracture, it goes around, kind of like the pattern of a drill bit would. Um, it turns out that transverse fractures tend to happen from getting hit laterally. Oblique fractures can happen from sort of movement of the body into a thing. And spiral fractures tend to be caused by a twisting motion, which kind of makes sense. Um, Impacted fractures are when the bone gets pushed together really hard. So think about like jumping from the second story roof and landing on your heel. That force pushing up on the bones causing a fracture would be an impacted fracture. A comminuted fracture is any time you have more than one piece of, more than two pieces of bone. So every fracture results in two pieces. A comminuted fracture would be three or more. And these are going to be problematic because they tend to be less stable and harder to immobilize. And then a green stick fracture you can kind of ignore. This is exclusive to children. And it's when their bones are growing, they're so soft and pliable, they can kind of break like a sapling, where half of the stick breaks, but the other half bends. And again, those are sort of limited to children up to probably 8 or 9 years of age. Okay, so let's start at the top and we'll move down. You have a shoulder. Your shoulder is made up of three things: your collarbone or your clavicle, your shoulder blade or your scapula, and your humerus or your upper arm. These three things clip together to form a ball and socket joint. So when you feel the end of your shoulder out here, what you're actually feeling is your AC joint, where your acromion and clavicle come together, hence AC. And those two things sort of just hold your shoulder blade and your arm off to the side. This is why you can move your arm sort of backwards a good amount, because you can pivot around that point. And this is great because it allows us to swim and it allows us to climb. The problem is we can also take our arm out of that socket pretty easily. What you see in the bottom left corner is an anterior dislocation of an arm. And you can see that on the right side, or over here, if you can see my cursor, he's got a clavicle that comes out normally. And on the left side, it's sort of a little bit more prominent. And now we've got this little bump here. And that's actually the head of the humerus sort of sticking out. And in this situation, what we need to do is we need to put that shoulder back in. Now, ideally, you would have a medical professional do this or at least talk you through this. With that being said, if you're a couple days out and somebody's got their shoulder out, putting it back in is going to be better than leaving it out for a couple days, both because the person will heal faster and be more comfortable, but also because leaving it out longer can actually be problematic. The pictures in the bottom corner are two ways that you can put a shoulder back in. Keep in mind that again, if you're out on the Chesapeake or down in the Keys and you're going to be back in at the end of the day, this can be done a couple hours later if the person has functionality of their hand. If they don't, then we've got to do this more immediately. Putting a shoulder back in is not comfortable. There's a lot of technique to how to do it. But it is not necessarily the most painful thing in the world. And as soon as it goes back in, there's a lot of relief generally for the person suffering the injury. You see the picture in the bottom right-hand corner. One of the ways to put a shoulder back in is to just exhaust it by pulling down on it. And the easiest way to do this is with a weight tied to the person's wrist while they're laying off of a table. So if you imagine that this person was like laying on a table in the salon and you had like 2 gallon water jugs tied to their arm, be about 17 pounds of weight. And eventually it would slowly tire their arm muscles out and pop their shoulder back in. The pictures in the middle here show something called the Cunningham technique. And the Cunningham technique involves having a person put their arm on your shoulder. And what you're going to actually do is put your other arm on their bicep and sort of slowly pull down on their arm. And that's going to lower the ball and allow it to pop back into the socket. Again, I would watch a video or two on this so that you can see it. I didn't really know if that would go well playing on the webinar, but it's not a difficult technique. There's not a lot of force being used. And the thing that I think is sort of underrepresented in a lot of the videos is that the doctor is actually like doing a massage of the person's arm throughout the whole process. And the goal is to relax those muscles because, again, if the muscles relax, it's easier to put the joint back into the space it's supposed to be. When the muscles are all tight, it can't get the ball back into the socket because it's stuck over here. And so we need to relax them so that we can put it back in where it goes. Bad news. If you dislocate your shoulder once, your odds of doing it again are higher. You dislocate your shoulder twice, your odds of doing it again are a lot higher. So you might hear of a person who's dislocated their arm 3 or 4 times. And at that point, that person's ball and socket joint is so loose that it's easy to just pop the thing in and out. So good news, if you've dislocated your shoulder a bunch of times, putting it back in is probably also easier. The first time I dislocated my shoulder, I was swimming butterfly, and I caught another person's arm over the lane line swimming butterfly. So pretty high impact. The second time that I dislocated my arm, I was putting on a shirt with my arm over my head. And the third time was washing my hair. So now I do a lot of arm circles to keep my shoulder tight and to try and prevent that from happening. But at some point, I'm going to have surgery. Okay, arm dislocations. So again, your arm in this top right picture is made of one bone at the top. This is your humerus. And then you have your radius and your ulna. Keep in mind that if my thumb side of my hand is my radius and my pinky side of my hand is my ulna, when I spin my arm, I've crossed my bones. And so again, the forearm's a little bit complicated because we can twist our arm a good amount. And when we do that, the elbow bones stay straight attached, but the wrist bones move with the wrist. So you're seeing sort of this like crossing piece of those two bones. When we talk about splitting the arm, you want to try and make sure that you're correcting the problem they have. So if someone has a humeral fracture, they actually want to tie their wrist to their neck. And that's the picture you see in sort of the middle right. It's called a cuff and collar. And that allows the weight of the arm to sort of pull the bone ends apart so they're less painful. And it keeps the limb against the body so that it moves naturally with the person. If need be, you can also apply a swath to wrap the arm into the body as well. Back to what I said about your wrist, since I can do this, if I break my forearm, I need to prevent this rotational movement. And so what we do is we build something called a sugar tong. And that's that the splint comes down around the backside of the elbow and up the other side, kind of like tongs you would use to pick up a sugar cube. This is going to prevent the side-to-side doorknob light ball motion because now it's going to be locked in on the top and the bottom and prevent those bone ends from moving. Again, the only other piece of this would be if you had an elbow injury by itself. And in an elbow injury, sometimes you need to support the whole arm with like a little bit of a splint here, or we can put you in a sling if you can tolerate it. Okay. Fun facts, your radius is about 80% of your wrist and 20% of your elbow, and your ulna is about 80% of your elbow and 20% of your wrist. So if you look at the taper of those two bones, that's sort of their reliance in those two situations. This was a guy during the Olympics who dislocated his elbow, and it was on TV, so I can show you that person's face. Okay, by far, the most common injury that we see in the emergency room, regardless of modality in terms of orthopedics, is called a FOOSH injury. And FOOSH stands for fall on outstretched hand. This is the, oh no, and we put our wrist down, and when we fall, our palm hits the ground, we get an abrasion, and we end up breaking off the tip of our radius on the thumb side of our hand. It happens all the time. It is easier to do if you have more brittle bones. You see this sort of characteristic dinner fork shape where there's like a hump right about where my watch would be here. And the good news is this is fixable. The bad news is that it needs to be put back together somewhat carefully. And so this is one of those situations where you might have to cause somebody a little bit of pain by pushing on the broken bones to get them into the right position before splinting. Hands and fingers. So again, when we talk about a broken finger, you might have discoloration and it might just be very painful and swollen. You can see in this picture here that there's like a loss of definition of the finger and some black and blue. This is a fracture where it's pretty obvious that we're broken and dislocated probably. And then here, like it's crooked, so this could be just a dislocation. Um, Putting a finger back in is pretty straightforward. You can pull on it, put it back in place. Some people do this for fun. It drives me nuts, but it is the same technique. Again, if you have a fracture and a dislocation, you don't really want to pull on a fracture. So we need to be careful in that regard. And then in terms of splinting, you can use anything, including another finger, but you could also buddy tape your fingers together or buddy tape a popsicle stick to your finger or use a purpose-made splint. I personally think that having an aluminum finger splint on the boat is a good idea for 3 reasons. One, they're pretty durable, and if you bang it on something, it'll go away. It won't, you won't injure yourself further. Two, if you have one of those splints on, they have a sponge in them, and the sponge doesn't absorb a lot of water. Or when it does, it can dry out. And then the third part would be if I have to sew up your finger, this is a great way to protect those sutures while they heal. So we're moving on down to the lower body here. So we have hips. Again, just like your shoulder, you don't have a hip bone. So you have a pelvis and a femur. And your femur clips into a ball and socket joint in your pelvis. And that's what gives you sort of the good hip mobility that we have. But it's also going to be a problem because if we dislocate a hip, we're talking about infinite more strength in those muscles than we were in the shoulder. And as a result, this can be very difficult to fix. And you can often make things worse by trying. Again, never try and put a hip back in without talking to a doctor first. For the most part, this isn't even something we attempt to do in emergency medical services or on the ambulance or helicopter because the risks are high and the success is low. Anytime that someone has a dislocated hip, they're going to have a limited range of motion based off of what direction they can't move in because of whether or not they've dislocated either anterior or posterior, just like a shoulder. Okay. So you can see here that this person's limb is rotated inward. Internal rotation of the afflicted limb is a common presentation for a hip dislocation. The knee itself, we'll talk about the femur here in a minute, but when we talk about the knee, there's sort of 3 problems. You could break either your upper or lower leg. You could break your patella, or you could tear something or dislocate something. So let's talk real quickly about dislocation. If you dislocate your knee, that's the 2 pictures on the right on the top. You've got a problem where these 2 surfaces that are supposed to be like this are not. And the problem isn't the bones aren't oriented right. It's that you're almost certainly cutting off blood flow to your whole lower leg. So this is a limb-threatening emergency and typically also, therefore, a life-threatening emergency where we're going to want to get you off that boat and to a surgically capable facility as quickly as possible. Conversely, a kneecap dislocation is pretty common. And it looks like the picture in the bottom middle there. And what that doctor or practitioner is about to do is take their 2 thumbs and go like this, pop, and just pop the kneecap back over the top. In the hospital, we like to tell people like, oh, we have a few questions for you. Why don't you look over there and fill the pop? And we surprise them with it. And I know that sounds heinous, but if you tell someone, hey, 1, 2, 3, I'm going to do this, they tense up and that makes it harder to do. So a lot of times people will come in and they're, what are you going to give me for pain? And we're like, oh, we'll get you some medicine. And while we're talking to them, we're massaging their leg, we're loosening those muscles up. And as soon as we feel enough play in the patella, we're going to just pop it back into the middle of the knee. And all of a sudden, they've got a little bit of an ache in the leg, but all that pain went away. You can also have ACL, LCL, and MCL tears, or what I like to call the football related knee injuries. Um, there's a lot of ways to injure your knee. You have an ACL, an MCL, and an LCL. This just stands for something ligament. So anterior, front, medial, middle, and lateral side. And so you need all three of these ligaments to hold your knee together. And if you tear one of them, your knee will be able to freely move or float in directions it's not supposed to be. Tearing more than one of them is obviously worse than tearing one of them, and tearing one of them all the way through is worse than only tearing a piece of them. So again, back to our grade 2s. If you have a grade 2 knee injury, at the very least it's attached. We want to be careful. But if you have a grade 3, we tore all the way through it, and now we've got to figure out how to fix this person. Again, down here, you can see the patella off to the side, whereas up here, you can see this is the tibia here, and this is the femur here, and these two things are not aligned because of this dislocation. Ankles. So the ankle is one of the most commonly injured parts of the body in sailing, and that's because we're on them, we're not kind to them, we're often not paying attention to where we put our feet, and again, like I said, unstable platform, uneven footing, yada, yada, yada. In Canada, there is a less litigious population than in the United States. And that might come as a surprise to some of you, but it turns out in Canada, they have a medical system where suing the doctor is not as prevalent as in the United States. And what that's allowed is Canada to produce some really interesting tools that probably would have been hard to develop in the United States. And the Ottawa rules are 3 of them. We're going to go over here. I think that these are not worth you memorizing, but they are worth having it like downloaded or somewhere. Because if you ever have an ankle, a knee, or a foot injury on the boat, this is what we're going to do at the hospital to figure out whether or not you need an x-ray. And if you don't need an x-ray, then you don't need to come. So the way the Ottawa rules work is that if the rules are negative, you have a 0.3 chance of a fracture. And so you don't need an x-ray. And the questions are pretty simple. After you injured yourself, were you able to walk 4 moderately normal steps? They don't have to be perfectly normal, but we also need you to actually bear weight on that limb. Not only were you able to do it immediately after the injury, but are you able to do it now? And so the now in the Ottawa rules is at the time of evaluation. And the way I would read that is that if the X is the injury, then X plus an hour or 2 is on evaluation. So can you do it? And then can you do it later on when the adrenaline is worn off and the swelling has started? And then X-ray if tenderness to palpation, TTP, I abbreviated that on one slide, but not here. And that basically means if I push on it, if I push it and like not super hard, like I'm not trying to hit them, but if I push on it with like a relative amount of force, does it cause pain? And we're going to push in 2 places. The distal or furthest from the center of the body, posterior lateral malleolus. $10,000 word for the ball on the outside of your ankle at the back. And medial malleolus, ball on the inside of your ankle on the back. So 6 centimeters is about 3 fingers. And what you're trying to figure out is when I push where that white box is in this picture, do they have increased pain? Because if the answer is no, and they could walk after the injury and they could walk at the time of evaluation of the tenderness, then there's a 98.7% chance that this person does not have a fracture. And so that x-ray is not necessary at all. No, 99.7. I was right the first time. Bad math. So again, super powerful rule. You don't see it used much in the United States because we just say, screw it, get them an x-ray, they won't complain. It's a goodie bag. But This study is not new. This has been out for a while. This holds true, and is a rule we frequently use in the emergency room to decide whether or not we need to worry about you. Okay, I'm going to come back to this slide in a minute. This is just an articulated picture, but again, this is looking from the side. This is looking from the middle. So these are two separate pictures of the same foot. And this is that distal 6 centimeters of the posterior lateral malleolus. And this is that distal 6 centimeters of the medial malleolus, or the ball on your ankle in the back. Okay. The Ottawa foot rules are pretty straightforward. Same thing. 4 steps at time of injury, 4 steps at time of evaluation. If no, we can walk, great. Then we're gonna push. And we're gonna push on the navicular and the 5th metatarsal. Okay, so here we're looking from the heel under the tibia, the second bone in line. So if you push from here downward and you push up from the bottom, you're going to be compressing the navicular, and the base of the 5th metatarsal is your pinky toe, where it connects to your foot. So you come all the way up the foot to where you get to sort of the chunkier part of your ankle. You can see that it's sort of in line here with where your leg connects, and you're going to push on the end of that bone. Same thing, straight down, push on that bone. And if you don't have any tenderness to palpation, then again, we don't need an x-ray. And then for the knee, this one's pretty straightforward. Again, 4 steps, time of injury, time of evaluation. We're going to see if they have any pain on the patella or the kneecap. And then we're going to push on the head of the fibula. And the head of the fibula is going to be the external bump on the outside of your calf on both sides. So on the outside of your knee, around the side, there's a little bump, and that's the head of your fibula. So again, these rules are what we're going to use to decide if you need an x-ray. And if you don't need an x-ray, then there's no point in going to the clinic. Down here at the bottom, we have x-ray if greater than 55 or an inability to flex the knee to more than 90. What I would say is that in all people, the more potentially brittle your bones might be, the more problematic this becomes, but it doesn't make the rules less accurate. So again, I don't think you need to memorize this, but I do think like having a breakdown of the Ottawa rules on board so you could follow it is a great idea. We end up sharing resources with boats all the time when they have an ankle related injury, and we'll actually hop on a video call with them while they walk through the exam, and we'll say, oh, you need to like be a little bit further to the right or a little further to the left or push a little bit harder than that, and let's make sure we're getting a good result out of this person. So this is just a cartoon of all of the problems so far that we've talked about, but we've got an open fracture here where we can see the bone. We've got sort of arthritis is when you have swelling of a joint, literally translates to swelling of a joint. And these can be problematic. Typically, they are treatable with non-steroidal anti-inflammatories like an Advil. But again, if they get hot to the touch, then we might be worried about an infection in there, and that can be sort of a limb-threatening problem. And then compartment syndrome we haven't talked about just yet, but we'll show you a picture of that in a minute. But that's basically when you break too much muscle and the compartment starts to swell. So you can see on the right, the leg on the right side has good sort of uniformity to it. You can see the tissue is sort of draped over the body, whereas the leg on the left is like taut and swollen. And that's because they're pumping blood into the leg, but it can't get out. So it's just inflating like a balloon. And eventually that'll stagnate and it will lose its pulse. So this causes pain. It can lead to pulselessness. It'll first turn bright red and then it'll eventually get pale. And these people frequently can't feel their toes or their foot after, an hour or two of accumulation here. I did not put any pictures in of how we fix this, but you actually have to fillet open the limb so that the swelling can reduce on its own. This is just an immediate evac consideration if you see swelling in a leg like this that's on one side only. Okay, so what are we going to do? This is all good information, but you guys don't have an x-ray machine. So we've got the Ottawa rules, and we can also cheat. There's a couple really interesting things that you can do on the boat. One, and these are three things that I think everybody should have on their boat if they're going cruising. One of them is a tuning fork. Sounds really silly, but these things are inexpensive. They're like 10 or 12 bucks. I put a price list for the build out at the end of this for all the things I'm going to talk about. A stethoscope, and you don't need an expensive one, but it turns out if I take a tuning fork and I bang it and I put it on my wrist and I listen to my elbow, if I can hear the sound, I don't have a broken bone. So what I can do is I can test my non-injured side, listen for the vibrations from the tuning fork through my bone to my stethoscope, and then compare that sound to the other side. And if the sound is significantly less transmitted, then it's because there's a break in the vessel that's communicating the sound, in this instance, the bone. This works really well. You don't need a tuning fork. In theory, you could put like really loud headphones on an ankle, but this doesn't take batteries and nobody's going to use it for anything else, and they're relatively inexpensive. Sorry, it's hiding from me. But yeah, just a little tuning fork. A pulse oximeter is helpful because if we're trying to figure out if we need to readjust your limb or evaluate if our splint is working well, one of the things we see a lot is that people put splints on too tight. And so a pulse oximeter is an objective way of measuring blood flow to an extremity so that you don't have to describe whether or not the two feel the same in words. You can compare the data between the blood flow to the injured arm and to the uninjured arm. And if they're the same or pretty close, we can call that good neurovascular function. Splinting, if you've ever tried to make a splint, you could buy all the material in the world to make all the splints the right way. But sometimes a little bit of ingenuity is going to work out better for you. Three things that I think you need to have on a boat. One of them is going to be duct tape, because you can make a splint out of duct tape. You can make anything into a splint with duct tape. It sticks really well, even in wet, humid environments. I've found that you can actually use Gorilla Tape sometimes in the water, which was pretty wild. But again, I'm a big proponent of a strong and reinforced tape. We want to avoid any pressure points. So if we're going to make a splint out of something hard, then we need to pad it adequately. We're going to make a splint out of something softer. We probably don't have to worry about that, but we might have to worry about how we're going to move that splint if it's not structurally sound by itself. Again, waterproofing. If you have a splint on and you're going to need to take a shower, that splint's going to get wet. And so just considering the materials we use, cardboard makes a really great splint until the second day that it's outside in the Caribbean and it's damp. And that's just from the humidity. This was someone made a splint out of two bananas. Nailed it, right? Like it needed to be that shape. The banana was the perfect shape. So here we are. It's important to splint your ankle at 90 degrees. That is that your calf or your shin comes down and your foot is at 90 degrees to your shin. And that's because if you heel in a bad position, your connective tissue can get too tight or too loose, and it takes a lot more time to rehab that injury if you don't have it in the right orientation. The wrist should be in what we call the beer can position. That is sort of the position you would be in if you were holding a cup. And that's like cocked up 30 degrees. I like to just put a cold beer in their hand while I'm splinting them because it gets a little bit of cooling to the injured area, and is also going to ensure that they can hold a beer can later on. Again, the hand should be at about 50. So you saw how we did this. If I have my wrist at 90 and my fingers sort of wrap around a can, that's at about 50 degrees there. So it's going to be good for me. And then again, the knee, you just don't want the knee locked. You want a little bit of flexion to it if you're splinting a lower leg So we would tend to put something behind the knee to give it a little bit of lift. And then access. If I'm going to need to evaluate whether or not you're getting good blood flow to your toe tip or to your fingertip, I can't cover all of them because then I can't do that. Okay, so things that I think are worth having on your boat for $1,000. This whole list would be $375. Some of the things you probably already have. An ankle stirrup like this, an air cast. These things are great because they allow for lateral support of an ankle while walking. They're waterproof, reusable, reversible, and effectively have like a one-size-fits-all design. A pulse oximeter, again, the only thing I'll tell you is that if you buy the $10 pulse ox, you typically get a $10 pulse ox. I don't think you need to buy a $200 pulse ox, but I probably would stay like above the $20 range. The quality seems to be notably better as soon as we get into the $20 to $30 range. For the record, all of my prices at the bottom, $375, is if you spent the most amount of money that I wrote here. So for my calculation, the pulse ox that I bought was $75. A stethoscope. This is the other item where being a little bit more spendy can get you a lot more quality. You really want to have a metal bell to this end of the stethoscope, and you want to have good solid tubing because again, this is going to help you hear. You can get a digital, they sell $1,000 stethoscopes. I think this one is probably about $250, and it has a little Bluetooth piece on it so I can listen to it on my earbuds or send a lung sound or a sound to a doctor over telemedicine. Tuning fork, again, helpful in determining fractures. Vet wrap, Coban or Ace wraps, something to secure a splint. Coban and vet wrap are the same thing. One of them is a lot cheaper because it's supposed to be for animals, but it works great on people. So for my kits that I build for my friends, I buy vet wrap because it's way cheaper. You can buy 3M's version of it for people called Coban, and it comes in pretty colors. But the advantage of this is that it sticks only to itself. It's disposable, and it does hold up when it gets wet. So it's not a tape problem. It doesn't hold moisture. It's relatively inexpensive, and it can be tossed out when it's done. I like this for splinting and bandaging because, again, it only sticks to itself. So when you go to take it off the person, you don't take any of their skin or scab with you. A SAM splint, that's the picture in the top right-hand corner here. That's also the picture around this guy's neck and this guy's ankle. It is a piece of sturdy aluminum foil between two pieces of foam, and it allows you to mold that splint into any shape you need it to be. All rolled up, they're about the size of a coffee cup, and they cost about 15 bucks. An arm sling, you can make an arm sling by putting somebody's t-shirt up and tying a knot in it, but having a sling allows them to have a little bit more breathability here for any shoulder or upper arm related emergencies. A knee immobilizer, I think this is a huge one. It takes up a little bit of space. They're not expensive here, but if you try and buy them abroad or at a Caribbean pharmacy, they tend to be. And if anybody steps into the dinghy wrong, this is a great thing to be able to just let them keep on living without any risk. A wrist splint kind of like looks like a rollerblading wrist guard. That way you don't have to make one. You'll notice that there's a splint for a wrist, an ankle, and a knee in here. And that's because those are the three things that are most likely injured. And they tend to have good one-size-fits-all appliances that are pretty adjustable. Excuse me. A tourniquet. Not super relevant to today's talk, but while I was talking about this, I thought about the fact that bleeding needs to get stopped too. And we didn't really talk about that in this series too much. So a tourniquet to stop any life-threatening bleeding, super helpful. An aluminum finger splint like these, again, they are inexpensive and great if you cut your finger and need to keep it still, or if you injure your finger and need to keep it still as well. So again, as we come to the end of this talk, things to consider before we go on our cruise, talking to our doctor, because again, if we have a risk for a fracture, then bringing one of the appliances to manage it is going to be all the more important. understanding what medications we need to have on board and access to. Again, I think every boat needs some form of antibiotics to manage an infection at a minimum, as well as some over-the-counter management stuff. Training, the more classes you take, the more you know, the more comfortable you will be in an emergency for yourself or for a loved one. And then again, as always, we appreciate you being here. This is the QR code that I talked about. If you wouldn't mind dropping me a line, and I would be happy to answer any questions there or in the chat. I do see one question about ice versus heat. So in a fracture, ice is going to be helpful. In a dislocation, it's going to make it harder to put back in. So if you think there's a fracture, putting ice on it can reduce swelling. Just remember, you don't want to make it too cold. Peas, frozen vegetables tend to work relatively well with like a towel or something. And again, it should be like 15 minutes on and then give it a rest. Elevation is also going to be helpful here. The age-old adage of like rest, ice, elevate, and compress. The other piece to the heat argument is it'll be helpful down the road, but not in the initial management. And in a dislocation, it might be helpful in helping to relax the muscles, but it will increase pain and blood flow.
Okay, does anybody have any? I think you covered some stuff that I know I wasn't fully aware of. And yeah, any questions from anyone? And they don't have to be just musculoskeletal. We'll open the
Yeah,
door to,
fire them at me.
yep. All right. Well, everyone knows where Amazon is, and they even deliver down here in the Caribbean. So again, Alex, thank you very much. This has been a really great, informative one. Watch your toes, everyone. I speak from experience. No breaks, but we also know a lot of other people who have had broken toes. So that's one. All right. So I think at that point,
Toes and fingers.
yes. Yeah. Lots of squished fingers. We'll wrap this up and see you for the next session on gastrointestinal and seasickness. And again, if you have anything that you want covered, email me, email Alex, and we'll make sure we capture it in the last recording, in the last session.